Chapter 9 discusses inflammation, tissue repair, and wound healing. So we'll start with what we call the cardinal signs of inflammation. These are the signs and symptoms or clinical manifestations you will see in your client, typically as a local response to inflammation. When we discuss the overall process of inflammation, we will also consider how the inflammatory responses that we go over contribute to these clinical manifestations that we ultimately see in our clients. And so those are what we call rubor or redness, tumor, which refers to swelling, calor, which means heat, dolor, which is pain, and finally loss of function. So again, these are all the cardinal signs of inflammation that we see locally when there is an inflammatory response. The other thing to understand about inflammatory conditions is that they are named by adding a suffix, which is itis, to whatever organ system is affected. So if the inflammation is, for instance, in the pericardium, which surrounds the heart, we call that pericarditis. If it's inflammation of the appendix, we call that appendicitis. So that's an easy way to know that there's inflammation and where it is located. So inflammation is the reaction of vascularized, so tissues with blood supply, to injury. Inflammation generally localizes and eliminates microbes that might be infecting the site. It can surround things like foreign bodies or particles, and it can also go in and eliminate abnormal cells. And the final thing that inflammation does that's very important is it paves the way or sets the stage for repair of those injured tissues. So all these factors involved in protective responses and bodily care, repair, so the inflammatory reaction starts first, and then we have an overall immune response. And finally, we have tissue repair and wound healing following whatever injury sort of started this process. So inflammation is often closely associated with infection, but that isn't the only cause, of course, of inflammation because as we said, it's the response to injury of any vascularized tissue. So anything that damages cells and tissues can cause inflammation. So things like infection from microorganisms, trauma, surgery, exposure to caustic chemicals, extremes of heat and cold, or any ischemic damage to body tissues. These are all things that can cause degrees of inflammation. So the first thing we'll talk about to kind of set the stage for our discussion of inflammation is the role of the endothelial cells. So the endothelial cells, one is to create this selectively permeable barrier. They create a barrier between the blood. So you can see the endothelium or those endothelial tissues. That's the inner lining of that little blood vessel we have there in the diagram. So it's a selectively permeable barrier between blood and tissues that allows exchange of nutrients and waste products. And then during the inflammatory process, it allows things like the immune cells that are pulled to the site to start entering the tissue. So they arrive via the vasculature. The semi-permeable nature of those endothelial cells allows those immune cells to kind of filter through and start entering the damaged tissue to trap and start to isolate and kill those microbes. Another role of that endothelial tissue is to maintain what we call vessel patency, meaning the vessel is open and the blood is flowing. And one of the major ways they do that is through what we call antiplatelet and antithrombotic agents. So they release specific mediators that keep platelets from hopefully sticking together and inside that endothelial kind of what we call lumen or opening, and antithrombotic agents which keep any clots from forming so that that blood keeps moving smoothly through that endothelial tissue. The endothelial cells also regulate blood flow. So that's through vasodilator and vasoconstrictor actions. So sometimes we want our blood vessels to dilate or open up or become larger, and that's part of what we see in an inflammatory response. We have a lot of what we call vasodilation throughout that process. It brings more blood to the area. And in the case of inflammation, it allows more blood flow to bring things like the immune cells that are going to be necessary to isolate microbes. So that's a necessary part of that inflammatory process. We also see in the inflammatory process, right after injury, we see vasoconstriction almost immediately, where the blood vessels kind of clamp down to initially really isolate anything that's there. That's a very what we call transient or temporary condition, but it's those regulators coming from those endothelial cells that are allowing that dilation or constriction based on the needs of local blood supply. Um, the endothelial cells are also crucial to the inflammatory response because they synthesize and release a lot of what we call inflammatory mediators. We're going to talk about many of those here momentarily, but a lot of them are released right from those endothelial cells. The endothelial cells also produce a lot of what we call growth factors that are involved in stimulating new blood vessel growth, and that's essential to the tissue repair process. Another thing to understand, though, about endothelial tissues is that they can experience significant pathology in people with inflammatory disorders, and this is going to become important later on with many of our discussions around things like micro and macrovascular diseases, different complications of diseases, things like diabetes, atherosclerotic plaquing. All of these things we kind of talked about with the inflammatory role of endothelial cells can also cause damage and disease in people with inflammatory responses. Okay. Endothelial tissues also help to regulate and modulate immune response. We'll talk about that a little bit, how they help to pull and bring all of those immune cells to the area, and they participate in the repair process of injured cells and tissues. There are also several cell types that are involved in the overall process of inflammation. I have them kind of listed here. We're going to talk about three of them. A few things like collagen fibers and fibroblasts and elastin. Those kind of pieces become really important when we start discussing the actual wound healing process towards the end. But some of the cells of inflammation include platelets. So when we think about platelets, you may be most closely aware of their function in blood clot formation. So that primary hemostasis function that works to control bleeding. But they also release a lot of the inflammatory mediators that we're going to talk about in a moment. And there may be, I think, according to your textbook, something like potentially 300 different chemical mediators that platelets can release at various times. So they're very active cells in this process of inflammation. The other cells are things like neutrophils, monocytes, and macrophages. These are immune cells that have what we call a phagocytic action, meaning that they go in and if there's a microbe present or a damaged cell, that needs to be eliminated, they will literally, to phagocytose means to eat. They will just kind of engulf those abnormal cells or invading microbes. They also, just like platelets, release different chemical mediators in the inflammatory process. And finally, eosinophils, basophils, and mast cells. These are cells of inflammation that largely work to produce cytokines, which are chemical mediators that produce a lot of the inflammatory responses that we see. So I've mentioned inflammatory mediators or chemical mediators several times. So let's talk about some of the specifics surrounding inflammatory mediators. So they have many functions, including what we call vascular permeability and vascular dilation. Chemical mediators also function as what we call chemical attractants, where they pull leukocytes or those immune cells to the area of inflammation. They can also induce the start of clotting activity at the site of injury. Chemical mediators are responsible for doing things like causing pain at the site of inflammation. And they can also exert systemic effects that we see in inflammatory responses. So, an example of a systemic effect of inflammation may be something like fever that we see in that inflammatory response. And chemical mediators can also exert antimicrobial effects where they actually help in the destruction of invading microbes. So the first chemical mediator will talk about and focus on, and I'll tell you there are a lot of chemical mediators that I'm not going to go too deeply into. There's just a lot of them. So I'm going to focus on some that I think are important to understanding maybe some of the pharmacology you guys will discuss. We won't go into all of them. But one that is very important is the inflammatory mediator of histamine. You're probably familiar with histamine because of its role in allergy reactions. But histamine is stored in mast cells. And so some of those inflammatory cells that we discussed earlier actually sit there and store histamine. And so if there is an inflammatory response, histamine can be released immediately because we have it kind of readily available stored in those mast cells at all times. So it's immediately released in response to some sort of stimuli. It has a lot of actions that you can kind of see in this picture, but we're going to focus on a few of them as they relate to inflammation. So one action of histamine release is that it dilates arterioles. So it causes dilation of blood vessels. And you can kind of see that in the picture here, where those blood vessels, this would be kind of a normal blood vessel here on the right, and they dilate to become larger. And this helps to bring more blood flow to the site of injury. It brings with it more chemical mediators. It brings with it more immune cells and different things that are going to be necessary for that immune response and later for tissue healing. Histamine also increases what we call venule permeability, and you can see that right here in the picture. And so as the venules or the blood supply becomes more permeable, that helps to allow those immune cells that have been brought to the site by that dilation to start filtering their way through and into the tissues where they can kind of go after any of those microbes or to destroy any injured cells. Histamine also is a principal mediator of the immediate transient phase of increased vascular permeability. Okay. So a lot of kind of the swelling and inflammation that we see at the site is largely related to histamine as well. Another inflammatory mediator that we'll talk about are our cytokines and chemokines. These are interleukins and tumor necrosis factor alpha. So this is how, right here in the middle of the picture, is how these are kind of abbreviated. IL-1, those are interleukins, and TNF alpha, those are the tumor necrosis factor. There are a lot of different subtypes within these categories. But if we're talking about cytokines and chemokines, we're largely talking about interleukins and tumor necrosis factor. So these largely play a role in modulating the function of other cells. And so in my picture, you can see, you have bacteria or T cells that stimulate our macrophages. So these were one of those phagocytic cells that we talked about of the immune system. When they're stimulated, they go ahead and produce these cytokines and chemokines, and then they exert their effects on different cells. So one of their effects is on endothelial cells, which we talked about earlier at length. And so a lot of those functions that we see in the endothelial cells are largely driven by the chemical mediators of cytokines and chemokines. They also stimulate neutrophils, and they stimulate a lot of the acute phase response that we see in inflammation. So they do things like cause the fever response that we see systemically. They cause the systemic response of anorexia or loss of appetite. Their release can also cause hypotension that we often see in systemic inflammatory response, increased heart rate, increased release of corticosteroids, our stress steroids or hormones. Those are all the kind of systemic responses that these cytokines are responsible for. Chemokines, they're sort of uh, chemical signalers. So they work to recruit and direct the movement or migration of immune inflammatory cells to the site of injury. So their release helps to kind of pull, they're kind of like a beacon to all these other immune cells that start then coming to the area. So these things have a lot of different functions in this inflammatory response. Other inflammatory mediators, the arachidonic acid metabolites and the eicosanocydes. So two of the inflammatory mediators I would point out in this larger category are prostaglandins and leukotrienes. And so you can kind of see this here. So we have cell injury and inflammation. Cell membrane phospholipids help to produce arachidonic acids that then go through two different pathways to produce their inflammatory mediators. And here are my leukotrienes over here. Leukotrienes are very similar in action to the histamines that we talked about earlier, but as you can see in this picture, they need to be produced in response to injury or inflammation, unlike our histamines that were stored and readily available. So leukotrienes take a little longer to produce than histamine. Their actions are similar, but they tend to be more potent and last longer than the reaction that we see in histamine. So if you look at their responses, things like smooth muscle contraction, increases in microvascular permeability, those are similar actions, but leukotrienes are stronger and they have longer action. Prostaglandins, you see kind of over here in this pathway, they promote platelet aggregation, so they help with blood clotting, and they also produce some vasodilation and vasoconstriction actions. They also inhibit inflammatory cellular functions. Prostaglandins are also part of the pain and fever production response that we see. Another inflammatory mediator is nitric oxide. That's typically produced kind of locally at the site of infection. It helps to relax smooth muscle. It antagonizes or slows the platelet adhesion and aggregation. It helps to recruit or pull more leukocytes, some immune cells to the site. And it has some direct antimicrobial actions as well. So it helps directly in the destruction of microbes. Okay, so now that we understand the function of endothelial cells, we've talked about some of the key cells involved in this process, and we've talked about some of the chemical mediators. Now we can go ahead and start talking about the overall process of inflammation itself. So the vascular stages of inflammation include vasodilation, increased vascular permeability, and the production of what we call exudates, which are kind of like secretions or fluid products that build up at the site of inflammation. Okay. And a lot of these stages of inflammation are what directly lead to those cardinal signs of inflammation or those clinical manifestations that we talked about earlier. They also cause things like stagnation of blood flow to the site that helps to keep microbes sort of where they are. They work to form blood clots to prevent any further injury. These stages allow things like red blood cells, leukocytes, platelets, and other clotting factors to kind of come to the site, which is important in the overall process. The first stage of the inflammatory response is the vascular phase. So the vascular phase of acute inflammation is characterized by changes in the small blood vessels that supply blood at the site of injury. And so what we end up with is increased tissue edema or swelling at the area. So the stage begins with, as we mentioned before, just kind of a momentary vasoconstriction phase or narrowing of the blood vessels. And so right away after injury, the vascular tends to kind of clamp down or constrict. But that is a very transient or temporary process, really meant to kind of control any initial bleeding and kind of just wall everything off in that really early, just almost immediate stage. Right after that transient period, the blood vessels then rapidly dilate or expand in the area of injury. That vasodilation or opening of the blood vessels involves the arterioles and the venules at the site. So you can kind of see that in the picture here, arterioles and venules. So what brings blood to the site and takes blood away. And so what we get is an increase in capillary blood flow, and that causes the heat and the redness that we see as two of those cardinal signs of inflammation. We also see, along with vasodilation, this increased vascular permeability. And when the vasculature becomes more permeable or kind of more open or allows more things to kind of filter through from the blood supply into the tissues, we get this sort of outpouring of really protein-rich fluids, and that's what we call exudates. And that protein-rich fluid starts to filter itself into the extravascular spaces, or those spaces outside of those vascular compartments, and so out kind of into the tissues. So you can see kind of all these exudates, these protein-rich fluids, leaving the vasculature and starting to enter those extravascular spaces around it out into the tissues. That kind of piece is going to start to really cause a lot of the swelling that we see at the site of inflammation, with all that kind of fluid coming out into those extravascular spaces. As that protein-rich fluid or exudate starts to leave the vasculature, it reduces what we call capillary osmotic pressure. So this kind of osmotic pressure that lives in these capillary beds. When we lose that kind of pulling pressure inside the vascular beds, it increases the pressure kind of out here in the interstitium or outside of the blood vessels. And so that will also help to pull more fluid from the vasculature into this tissue or extravascular space. So an increase in capillary pressure and causes all of this outflow of fluid and accumulation into the tissue spaces. So again, that causes more swelling. It can also cause pain at that site, and it impairs function. So all of that kind of tissue swelling makes it sort of harder to move an extremity, which accounts for those other cardinal signs of inflammation. Okay. This movement of fluid out of the vessels causes overall stagnation of blood flow. That causes clotting to occur, but it helps to aid in preventing any spread. It kind of localizes any infectious or microorganisms. After the vascular stage of acute inflammation comes the cellular stage of acute inflammation. And this is when we get significant movement of those phagocytic white blood cells or leukocytes into the area of injury. Primarily, there are two types of leukocytes that are involved in this reaction and the acute inflammatory response. So there are granulocytes, which include neutrophils, eosinophils, and basophils. If you remember, eosinophils and basophils largely release and produce different chemical mediators. And also our monocytes, which are our large blood vessels that have that phagocytic kind of property. So neutrophils are the primary leukocyte that we see with the inflammatory response. Eosinophils, again, are largely chemical mediator producers. We see a lot of eosinophil production in things like allergic reactions or parasitic infections. Basophils, again, really release a lot of chemical mediators. They are similar to something like a mast cell, which releases histamines. And then monocytes, those typically arrive kind of after our neutrophils. They work a lot longer and they act as macrophages or phagocytic cells. So during that cellular response, we have kind of three pieces here, what we call margination, adhesion, and transmigration. So as the leukocytes start coming to the site, they kind of line up along the inner lining of the blood vessels, and that's what we call margination. And they basically kind of stick there to the sides of the blood vessels, and we call that adhesion. Once they stick to the inside of the blood vessels, they signal that endothelium, that lining, that semi-permeable barrier between the blood vessels and the tissues. They signal the endothelium to kind of start to separate, and that allows the leukocytes to start filtering through and entering into the tissues. And that's the piece that we call transmigration. This is largely driven by cytokines or chemical mediators that pull those cells to the site and help them line up and stick to the endothelial linings. So a little bit more about that kind of cellular phase. So again, the cellular phase of acute inflammation involves that delivery of the leukocytes to the site of injury so that they can start to perform their normal function of host defense through that phagocytosis process. Okay. That delivery and activation of the leukocytes is divided into different steps. So the first step is endothelial activation, then adhesion and migration, or excuse me, adhesion and margination, then transmigration, and then chemotaxis. So the recruitment of leukocytes to the precapillary venules is where they exit the circulation. Starts by the slowing down of blood flow and that kind of lining up of those leukocytes along the surface of the blood vessels. The leukocytes then kind of stick or adhere to the endothelial lining, and they start transmigration from that vascular space into the tissues themselves. And that's all facilitated by different adhesion molecules and different chemical mediators at the site. So then the leukocytes leave the vasculature and they migrate into the tissues, heading toward the site of injury. They're largely pulled by those by chemotaxis. Remember, we talked about some of my chemical mediators, especially my chemokines, act as sort of beacons or signalers. That's what's pulling these leukocytes along what we call kind of this chemical gradient so they can get to the site of injury. Okay, so we can see that kind of in the picture here, right? We have these little leukocytes that are kind of moving through my blood vessels. The blood vessels have dilated, allowing more of them to kind of come to the site. They're being potentially pulled by different chemokines that are saying, hey, this is a site of injury, come this way. So here they come rolling through the blood vessel, and they start to sort of line up along that endothelial lining. And then they are signaled to kind of start to stick or adhere. And then that semi-permeable barrier starts to open, allowing them to transmigrate and to kind of come through those blood vessels and end up within the tissue beds themselves. And then that little leukocyte can start to engulf or destroy bacteria that have accumulated at the site of injury. So again, once at the site of injury, the products produced when we injure tissue trigger a number of leukocyte responses, including that phagocytosis and cell killing. Um, so receptor activation triggers all this intracellular signaling, leading to the formation of what we call pseudopods that kind of enclose the microbe within a phagosome. So you can kind of see that here, right? So we have a leukocyte that comes to the site of injury. It is signaled to respond. It sort of engulfs that microbe here and becomes a phagosome and kind of fully engulfs and kills that microbe at the site. So, although all acute inflammatory reactions are characterized by those kind of vascular changes and leukocyte infiltration, the severity of the reaction that we see and its specific cause will produce a lot of variations in the manifestations and clinical signs and symptoms that we see. So that can range from different types of swelling. And one of the differences that we see in clinical manifestations are a lot of different types of exudate that are formed at the site. And so I'm going to go through some of the different forms of exudate here. These are terms and things that you'll hear anytime, during any class when you're discussing like different wounds. So when you discuss things like surgical wounds and their care, you're going to hear a lot of these terms and descriptions of different exudates that can form at the site of injury. So sometimes our exudates are what we call serous exudate. These are very common. This is a really common exudate, maybe following surgery or trauma. These are sort of watery fluid. They're relatively low in protein content. These are formed when plasma enters the inflammatory site. So what this looks like in a patient is kind of a really kind of clear watery discharge from the site of injury. We also have hemorrhagic exudates. These occur when there is severe tissue injury that causes a lot of widespread damage to blood vessels. And we have a lot of significant leakage of red cells from the capillary beds. So this is bleeding. This is when our exudate really looks like blood. Other exudates, we have membranous or pseudomembranous exudates. These are exudates that we see on mucous membrane surfaces. So things like in the nose, in the mouth, in the lungs. These are usually necrotic cells that are kind of enmeshed or caught up in this what we call fibropurulent exudate. But these are seen at very specific tissue types. We also have what we call purulent or supportive exudates. This is what we commonly call pus. And so this is made up of degraded white blood cells and proteins and different tissue debris that's kind of sloughing off, or is that kind of really thick white exudate that we're familiar with. And we also have what we call fibrinous exudates. These are like a really sticky, thick meshwork of fibrinogen that we sometimes see. An example of this that we'll talk about in probably in actually 2015 when we talk about pressure ulcers is something called slough, which is this like kind of yellow, really thick adherent exudate that we see at the site of an ulceration. Um, so another thing that we'll talk about is the difference between that acute inflammatory process and the chronic inflammatory process. So we've been talking a lot about acute inflammation, and that is a process that is of relatively short duration. It's also a really non-specific early response to injury, meaning that, as we mentioned, any injury, whether it's, trauma or surgery or infection, causes really the same cascade of inflammatory response. That's what we mean by nonspecific. And it's aimed primarily at removing an injurious agent, limiting the tissue damage, and then starting the overall healing process. We'll contrast that to chronic inflammation that is much longer in duration. It can be days to years where people have these chronic inflammatory conditions. And it's recurrent and progressive acute inflammatory process. It's more of like a low grade kind of smoldering response It doesn't evoke the same kind of level of acute inflammation. It's kind of just below that, but it just kind of endures. So, a little more about chronic versus acute inflammation. So, acute inflammation is usually, again, really self-limited and of short duration. We get that infiltration of neutrophils, we get exudates, really all of those things that we kind of just talked about with acute inflammatory process. Chronic inflammation is more what we call self-perpetuating, lasts a lot longer, weeks, months, or even years. We get more infiltration by things like macrophages and lymphocytes instead of overall neutrophils. So again, neutrophils is really the primary immune cell of acute inflammation, a little different in chronic inflammation. And then in addition to those cells, we also get proliferation of cells that we call fibroblasts instead of the overall exudates or fluid infiltration that we see in acute inflammation. And so when we get fibroblasts instead, those tend to be more of cells and components that are related to directly to like the tissue repair process. And so when we get fibroblast proliferation instead of exudates, we're more likely to have things like scarring, or tissue deformities happen with fibroblast production instead of exudate. So the healing that we see is different and usually not as, I guess I'll use the word efficient or complete that we see in acute inflammation. So certain agents also will evoke that chronic inflammation. And they are things that are typically like what we call low-grade producers of inflammation. So like persistent infections or irritants that are unable to deeply penetrate tissues or spread rapidly. So in an acute response, we have maybe an infection that's able to like really get into tissues and spread fast. And so it produces this large inflammatory response. If we have an infection or an irritant or something that doesn't really penetrate deeply or that keeps itself sort of selectively more localized, doesn't really spread, it also doesn't invoke that big inflammatory response, but it does invoke a response of some sort. And that's where we get sort of these kind of low grade or what we call smoldering chronic inflammatory responses. So some of the causes of chronic inflammation can be things like foreign bodies. So some example of this is like invasion by things like talcs or silicas or asbestos. So they're kind of foreign bodies that can get into the tissues, but just sort of sit there and they irritate, but they don't cause these big, inflammatory responses. Other common causes of chronic inflammation can be surgical suture materials. So any surgical materials kind of left behind do the same. They cause this kind of low-grade chronic inflammation that's problematic, but not this sort of big inflammatory response. Many viruses also provoke chronic inflammatory responses. There are a few bacteria. Fungi also do that. They don't penetrate as deeply, so they're more chronic inflammatory. Large parasites can also cause chronic inflammation versus acute. Granulomatous inflammation is a distinctive type of chronic inflammation that we often see in lung tissue as a reaction to foreign substances or infections. And it's a reaction to substances that aren't what we call easily controlled by other mechanisms. So a dense membrane of connective tissue eventually will come and encapsulate that lesion or invader and isolate it. Once that encapsulation and isolation occur, we call that those cells a foreign body giant cell. So some things that cause this response, so foreign bodies like splinters or sutures, silica or asbestos, which can get into the lungs, and then microorganisms like tuberculosis, syphilis, sarcoidosis, deep fungal infections can also cause these granulomatous inflammatory responses. So ideally, inflammation remains local. Um, so we're going to talk now about what happens when it doesn't, when we get those, as we referred to earlier, systemic or system-wide manifestations of inflammation. So the acute phase response of inflammation also includes systemic responses of things like skeletal muscle catabolism. That means we are kind of breaking down skeletal muscle. And the reason that we're doing that is to release different amino acids that are used then to kind of promote and support the inflammatory response overall. And so what we see in our patients is what we call a negative nitrogen balance as protein breaks down. We see something called an elevated erythrocyte sedimentation rate or increased ESR. We can actually test for ESR in the serum, or we can do blood tests for it. Patients with elevated erythrocyte sedimentation rates or elevated ESRs are understood to have some sort of acute inflammatory response going on. We also see, again, this increased number of leukocytes being produced. So again, we can do direct blood testing for that. We can draw blood. It's a complete blood count, and we can actually see those elevated white blood cell counts as the body is being stimulated to produce more of them. We see a systemic response of anorexia. So oftentimes when patients are going through this acute inflammatory response, they have a loss of appetite. They can also become sleepy or fatigued. They get kind of overall maybe body aches or weakness. So those are kind of the common systemic responses. And a lot of those systemic responses are driven by the chemical mediators called cytokines. Those TNF alphas and those IL-1s, those interleukins, are really responsible for a lot of these responses that we see. So again, white blood cell counts commonly increase from their normal value of about 4,000 to 10,000 or greater in those acute inflammatory conditions. Bacterial infections usually produce primarily increases in neutrophil production. Parasites and allergic reactions often produce an increase in eosinophils. Viral infections usually produce an increase in things like lymphocytes. Um, and so those are sort of the I guess, profile of the different immune cells we see with different invading microorganisms. Eventually, if a infection kind of goes on and starts to overwhelm our body's ability to produce white blood cells, in some later stages of those responses, we may even see what we call leukopenia, or a reduction in white blood cells as we sort of overwhelm the system in general. Another thing that we see in inflammation is this lymphadenitis. So lymphadenitis, I think is the way you say that. And so that is inflammation of the lymphatic tissue. And so we talked about this, I think, a little bit in a class maybe this week, but you guys will assess in 2015 a patient's lymph nodes. So you'll kind of palpate around in the neck and feel if there's any swollen lymph nodes. So painful and palpable nodes that you can feel, are commonly associated with the inflammatory response. If we have lymph nodes that we can palpate or feel, but they're not painful, those are usually more closely associated with neoplasms, or the increase in lymph tissue and subsequent metastatic disease that we see with neoplasms. Again, fever, largely driven by the action of cytokines and their action on the thermoregulatory centers in the brain. We're going to talk about that later on in the semester when we get to heat responses. And later in the semester too, we're going to talk about a concept called septic shock. And septic shock occurs when there is so much uncontrolled immune response, just this massive overall release of cytokines. And remember, one of the things that cytokines do is this vasodilation, increased vascular permeability. If that happens on a huge scale, we start to get really significant intravascular fluid loss. So the more fluid that leaves the vasculature and heads into the tissues, that can cause really severe hypotension in our patients. It can cause such severe kind of fluid loss in that vascular compartment that our cardiac function cannot continue efficiently because there's not enough fluid to kind of pump around. The blood pressure drops so significantly, and it can lead to the circulatory shock that we see in sepsis. Okay, this is probably a good spot to take a little break from the video because we are going to transition from the inflammatory kind of discussion, acute and chronic, to more of the wound healing piece. So great time to kind of take a mental break and come back to wound healing. Before we get into the overall discussion of wound healing, we're going to do a little kind of background discussion on some different tissue types that will inform the overall wound healing process and kind of what we see as the end products of that process as a whole. So the term regeneration refers to the replacement of damaged cells with the same cells. So regeneration is, I have a certain cell type. When I heal that area of damage, we replace the cells with the same type of cell, same functions, same abilities. But the ability for that to happen really varies based on the type of cell that we need to repair. So the capacity for overall regeneration or replacement with cells with the same type really varies by tissue and cell type. And we'll talk about that a little bit. But within body organs and tissues, we have a couple different types of tissues that form their overall structure and function. Parenchymal tissue contain the functioning cells of an organ or body part. So like in the liver, we have hepatocytes, and those are the cells within the liver that actually perform the specific functions we associate with liver function, or renal tubular cells that perform the functions that we associate with the kidney tissue overall. But we also have what we call stromal cells, and those are the supporting kind of connective tissues of that body organ or tissue. So that's things like the blood vessels, what we term extracellular matrix, the nerve fibers that, again, support and provide structure to those functioning cells within the tissues. So when we talk about cells that are able to sort of regenerate, we have sort of three different types. They're labile, stable, or permanent. So labile cells can continue to divide and replicate throughout their lifespan. And they are usually capable of replacing cells that are continuously being destroyed with new types, with the same type of cell. So epithelial tissues of all types are the cell types that are considered labile throughout the body wherever they appear. We also have stable cells. They normally stop dividing when overall growth ceases, but these cells, some examples are parenchymal cells of the liver or the kidneys, some of our smooth muscle cells, some of the vascular endothelial cells. They will regenerate when confronted with an appropriate stimulus. So these are cells that normally wouldn't regenerate themselves once growth stops, but if they're damaged or there's some other kind of stimulus that says they need to, they are able to undergo that regeneration process. Permanent cells are cells like nerve cells or skeletal muscle cells or cardiac muscle cells that cannot undergo any further mitotic division, and so they will not regenerate. So once they are damaged or destroyed, they will not regenerate or be replaced by the same type of cells. And so for repair to happen at a site of a permanent cell, these cells will be replaced by some sort of scar tissue during that wound repair process. So different factors that regulate the healing process, one of them, just like in inflammation, is the overall action of the chemical mediators and different growth factors that are involved in mediating that healing process. And also these interactions between what we call extracellular and cellular matrix. The chemical mediators and growth factors are released from different cells that participate in that healing process. When growth factors are released, they assist in overall regulation of the inflammatory response. They help to attract like different neutrophils and monocytes to the area of injury. And they also attract fibroblasts and epithelial cells, which are necessary for the wound healing response. Growth factors also stimulate what we call angiogenesis, which is the production of new blood vessels to an area of injury. And finally, those growth factors contribute to the generation of the extracellular matrix, or ECM. And that generation of the ECM is responsible and largely promotes the overall wound healing process. So two other terms or concepts that'll be important to understand, and these will come up kind of again and again in many of your classes when you discuss wound healing and the repair of tissue damage. And they are healing by either what we call primary intention or secondary intention. When something heals by primary intention, we have what we would consider a small, clean wound. And so up in my pictures, you can see this wound I have here. It looks like a surgical incision that is closed using some kind of suture material. You can see that the wound edges are pulled tightly together. We call that approximation, where those wound edges again are pulled tight, so they're sort of touching each other. The objective of any healing process is to really fill in kind of that gap created by tissue destruction, and also to hopefully restore its structural continuity. But you can see in this primary or first intention, there's not a whole lot of tissue loss. The tissue, is relatively intact, and that healing process happens usually a lot more quickly with less loss and overall destruction of tissue in general. The other type is secondary intention, and that's shown in the picture here. Much larger loss of tissue, typically more chance and almost guaranteed chance of some sort of tissue contamination. I think that's what's depicted here by all these kind of little dots. I think those are microbes. We often do examples of things that heal by secondary intention, any like pressure ulcer or injury to the skin where we have a large ulceration. And sometimes we, I guess, selectively choose to allow some wounds to heal by secondary intention. If you have a wound bed that's large and open and contaminated with a lot of different microbes, you don't want to take and suture and close it up and kind of essentially trap all those little microbes in an environment where they will love to kind of grow and spread themselves. So if a wound is contaminated with microbes, it's best to just leave it open and let it heal by secondary intention. And so it essentially heals from the bottom up. That way you don't trap microbes. This is why, like, typically if someone, maybe sustains like a really deep cut or something, we can suture those cuts, but usually after about like 24 hours or so after injury, we don't do that anymore because we end up just kind of trapping those microbes in place. Okay. All right, so when wound healing occurs, it happens in distinct stages. So we have the inflammatory phase, then the proliferative phase, and then what we call the maturational or remodeling phase. So the inflammatory phase begins at the time of injury, and it starts with the formation of a blood clot, as well as migration of those phagocytic white blood cells into the wound site. The first cells to arrive are usually our little neutrophils, and here they are. And they help to ingest and remove any bacteria and cellular debris at the site of injury. After about 24 hours, the neutrophils are joined by macrophages, which continue to help ingest and destroy any cellular debris. And they also play an essential role in producing all of those growth factors that we talked about earlier that are going to become essential in the next stage of wound healing called the proliferative phase. So here's the proliferative phase. The primary processes that occur during this phase focus on the building of new tissues that will help to fill in the wound space. The key cells used during this phase are the fibroblasts. Um, Fibroblasts are a connective tissue cell that synthesize and secrete collagens and proteoglycans and glycoproteins, which are all needed for the wound healing process. The fibroblast cells, here's my little fibroblast here, also produce growth factors that induce what we call angiogenesis, the overall growth of new blood vessels. So you can kind of see that here where we have new blood vessels kind of growing to replace any injured blood vessels and to make sure we have continued, of course, blood flow to that new tissue. And those growth factors also signal or promote endothelial cell proliferation and migration. So we have little endothelial cells that also need to come to the site to start really kind of filling in that wound space, right? The final component of this overall proliferative phase is what we call epithelialization, where epithelial cells at those wound edges start to proliferate and form a new like surface layer. And often it's similar to what was destroyed by the injury. So they just start kind of lining themselves up inside of that wound and start building, building, building to fill in that injured space. And the final phase is wound contraction and remodeling. This phase usually begins approximately maybe 3 weeks after injury with the development of a fibrous scar. And this process can continue for up to maybe 6 months or longer and really is dependent on the extent or size of the overall wound. So during this phase, there is an overall kind of decrease in vascularity. So you can see kind of less inflammation, less blood flow, less vascularity to the site, and this continued remodeling of scar tissue by synthesis of collagen and fibroblasts, accompanied with sort of lysis or enzymatic lysis or breakdown of other kind of tissues within the area. So we're kind of building up and breaking down at the same time while we sort of remodel and refine that scar tissue or wound healing. So as a result of those two processes, that kind of synthesis and breakdown of different fibrins and collagens, that architecture, structure of the overall scar is capable of increasing its what we call tensile strength. And the scar starts to kind of shrink, so it's less visible. So that's happening kind of well after the wound healing process. And the final thing we'll talk about are certain conditions, often conditions of our patient, that will impair or slow down overall wound healing. So one is malnutrition. You need protein for wound healing and for that inflammatory process to occur. So if people have malnutrition and they don't have enough protein, it'll slow down overall wound healing inflammation. You also need, during the wound healing process, you need the overall ingestion of carbohydrates. That helps to preserve the proteins that you have within the body for wound healing. So if someone's not taking in carbohydrates, then they need an energy source from somewhere. And they're going to get it from whether it's, breakdown of proteins, whether it's breakdown of lipids. And so now you're breaking down all of those components just to, power the body when you're also breaking those things down and using them for wound healing. So it's going to slow down the overall process as you're kind of like sharing those resources among two significant processes. So usually when someone is trying to heal a wound, we would increase their protein intake, we would increase their carbohydrate intake to sort of support those processes overall. Okay. You also need carbohydrates in that energy source to provide energy for the overall increased production of white blood cells. And you also need fats for the production of things like new cell membranes. We're making a lot of new cells during that wound healing process as well as we start to fill in those wound beds. Vitamins A and C are also essential to the healing process, and also the micronutrient zinc. So those are some other nutrients that we might prioritize during wound healing. Impaired blood flow or impaired oxygen delivery can also impair wound healing. Blood flow is essential to bring in nutrients to the site and remove waste products. If we don't have good blood flow, many of those inflammatory processes that we talked about are just not going to really occur. And that will impair all of that wound healing kind of all the way down the line. Anything that impairs our inflammatory or immune responses will also slow wound healing. So things like disorders of phagocytic function. So if we can't produce all of those phagocytic immune cells, conditions like diabetes, therapeutic administration of corticosteroid drugs or our stress hormones will also reduce that inflammatory and immune response. If we get infection to the site of wound healing, that infection will prolong that inflammatory phase. And if we get prolonged inflammation, it will impair the formation of what we call granulation tissue, or kind of all that epithelialization or new epithelial tissue that we need to fill in that wound bed. If there's an infection there, that process slows way down. The proliferation of fibroblasts, the depositing of collagen fibers into the wound cell is also impaired if there's an infection present. So we do need to treat infection at a wound bed to be able to go through that healing process efficiently and effectively. Other things that can impair wound healing, wound separation. So if the wound bed itself, if the edges of that wound bed are separated or not closely approximated, that wound will take a lot longer to heal. We kind of talked about that with primary and secondary intention. It just takes longer to heal with that wound bed sort of spread or separated. Foreign bodies also impair wound healing. So foreign bodies, we talked about a few of them already. Other ones that I would mention, like any left behind material from surgeries. Bullets are another example of foreign bodies. But they also, in addition to like being a sort of physical impediment to wound healing, they also tend to bring with them bacterial contamination that also delays wound healing. So again, things like sutures, surgical sponges, bullets fall into that category. And the final thing we'll mention as an impairment of wound healing is the effects of age. Typically, these are in the very young or the very old. So really young children, infants, neonates, they tend to have immature immune systems. So a lot of the different immune cells and immune functions just aren't fully formed yet. So they don't tend to heal as efficiently. And in older adults, same thing, we start to see sort of breakdown or less efficient action of the immune system overall. And older adults also tend to have less collagen and elastin in the skin, so that tends to heal more slowly. They also have a reduced collagen and fibroblast synthesis, so some of those essential components to wound healing just don't work as efficiently. That wound contraction phase often takes longer and is impaired, and that re-epithelialization phase of open wound healing is much slower in older adults.